Hi guys, welcome to this Potter series with Radiology World. This is Dr. Natisha Arora. I am a consultant radiologist based from India, and today I will be discussing head and neck radiology spotters, which are very commonly tested in your radiology residency examinations and also in your competitive examinations like FRCR and EDA. These are spotter series with 10 important images. You can pause the video as I show you the images, think about the diagnosis, and it will be followed by a brief description. So let's start with our image number 1. So you can see that this is the classical MRI T2 weighted image, a coronal image of the face region, and there is a very well defined T2 lobulated hyperintense mass. Okay, so this is a classical case of facial hemangioma. Okay, important thing to note over here is that with such large hemangiomas and such segmental distribution, they commonly test you for a syndrome which is associated with it, which is called as your faces syndrome. P stands for your posterior fossa malformations, H stands for your hemangiomas, A stands for the arterial abnormalities, which is commonly aortic coarctation, C stands for your cardiac abnormalities, E stands for your eye or ear defects, and S stands for your supraumbilical raphe or the sternal defects, basically any ventral wall abdominal defects, right? So this is very commonly tested. They will give you this classical T2 hyperintense lobulated image, or they can show you a T1 post contrast image that will show a very avid contrast enhancement also. And you can also sometimes being shown I'll just show you. You can be shown some phlovoids. Okay, if they give you these phlovoids, these are nothing but your calcified phleboliths. Okay, these are also commonly tested in the hemangiomas, right? So this is a classical spotter image of facial hemangioma. Okay. Let's move towards our image number 2 or the spotter number 2. This was also recently tested on a NEET PG examination. So as radiology residents, you should very well aware of this particular image. This is very important, very classical. You all must be knowing from your MBBS knowledge only. So this is basically your splitting of the external and the internal carotid artery, and you can see that there is an intense blush on a DSA image. Okay, so this is your DSA image, and you can see that there is an intense blush. Sometimes they will also show you an early draining vein because of its highly vascular nature. This is a carotid body tumor, also called as a chemodectoma or a extraadrenal paragangliomas. Okay, and you can see that over here. First of all, you need to know that how you will differentiate between ICA and ECA. You can see that there are branches over here. Okay, so branches always in the cervical regions come from the external carotid artery only. So this is ECA, and ICA will go straight up intracranially without any branches in the cervical region. So that is an ICA, and in between there is this large blushing tumor. Another thing to note over here, this is very commonly seen in females in around 4th to 5th decade. So the epidemiology is important to be known. And another thing is that in 10% of the cases it can be bilateral also, right? Now this is a same tumor, the carotid body tumor, and you can see that there is again splitting of the IC and the ECA. This is a CT image. Okay, so either they will give you a CT image or a DSA image. Important thing to note is that there is this classification system which you should know. This classification system is basically the circumferential angle of contact of the tumor with the ICA. Okay, so this classification based on this angle of contact of tumor with ICA, it is categorized under the Chamberlain group system. Whereas where group 1 is less than 180 degree of encasement, group 2 will be 180 to 270 degrees of encasement, and group 3 is more than 270 degree of encasement. It is important for the management for what type of surgery has to be done for the resection of the tumor, or whether the ICA resection is needed or not. So it helps in deciding that, right? So it helps in deciding the risk of ICA adventitial involvement and possible need of the ICA resection, right? So that is all about this particular Chamberlain group system classification for the carotid body tumors. Okay, so again, just continuing this spotter only, another sign which is commonly tested is your salt and pepper appearance. So the salt and pepper appearance is also seen in any other extraadrenal paragangliomas, right? This is mainly because of, if you see, if this is seen on a T1 weighted image, classically it is known for T1 weighted image. So you can see that if there is black thing, that will be representing your signal voids, whereas the white thing will be representing the hemorrhages, the punctate hemorrhages which are present, right? So this was again a case of an extraadrenal paraganglioma in the head and neck region, and this was having a classical salt and pepper appearance. Where else do you see this salt and pepper appearance? So this is, I'm just jumping from one spotter image based on the sign to another image. So this is classically seen with Sjogren disease. Okay, you can see that there is typical arrangement of bilateral parotid glands, okay, with this multiple cystic spaces in between, and the remnant gland is also present in this parotid region. This is also being called as the salt and pepper appearance. Another thing where this salt and pepper appearance is also seen as an HIV associated parotid glandular disease. Okay, so in the parotid glands in the HIV also show this characteristic cystic enlargement, and it is also seen with them in the HIV associated glandular disease, they say. Okay, so that is another thing where the salt and pepper is seen. Okay, and note over here that this is, I am talking about T2 weighted images, whereas salt and pepper in the extraadrenal paragangliomas, this was a T1 weighted image. Okay. Where else do you see the salt and pepper appearance? So again, this is again very important. So salt and pepper is also seen in vertebral hemangiomas. Okay, so remember, this is also called as the polka dot sign. If you just see the sagittal images, they will be having a jail bar or a corduroy appearance, whereas if you take the axial sections, they will give you this either polka dot appearance, or they will either have a salt and pepper appearance. Okay, so if you see this particular image, this is a CT image, and you can see that there is background may, you can see that this is fatty replacement of the marrow, so that is looking relatively black, whereas this white thing, that will be your basically the coarsen trabecula. So if you see it on a sagittal or a coronal image, it will look like this, but if you see the cross section, it will look like this, or salt and pepper or polka dot appearance. Whereas if I see an MRI weighted images, I am talking about a non-fat suppressed image, either T1 or either T2. You can see it on the background, this is a fatty white marrow, and this black things, exactly we can say the photographic negative of this. You can see this black things, this is again your bone. This particular part is the part of bone. These are coarsen trabecula. So this will give you this salt and pepper appearance on the MRI image. So that is about the vertebral hemangiomas. Let's move towards our next spotter. You can see that there is a very, so this is basically a plain image, and you can see that there is a very well defined hyperdense tissue or a mass that is seen just behind the tongue. Okay, so this is a case of an ectopic thyroid gland. Okay, so remember that the thyroid during its development, it goes from the base of cecum and it goes into the infrahyoid location, but if there is an arrest anywhere along this pathway, it will lead to an ectopic thyroid location. Most commonly it is seen in the lingual area, but it can also be seen either in the infralingual region, or it can be seen in the mediastinum as well. So clinically, these patients will be having congenital hypothyroidism. Okay, so this is very classical spotter image, which is commonly tested on the radiology residency examination also. You should know that this particular tissue on the plane is very hyper, which is because of the iodine content that is present in the thyroid gland. Okay, so this is a case of ectopic thyroid, an ectopic lingual thyroid gland. Let's move towards our next spotter image. You can see that there is a very well defined cystic lesion. Where it is present? It is present near the angle of the mandible. Okay, and it is also located anterior to your sternocleidomastoid. This is the sternocleidomastoid. Okay, so you can see that this is a case of branchial cleft cyst. Okay, so these are cystic remnant. These are cystic remnants from the branchial cleft apparatus, from the second branchial cleft apparatus. So this is a case of second branchial cleft cyst. Okay, so important thing to note is that this is usually located at the angle of the mandible, and it is also along with the second branchial fistulae, and sinuses can be also associated with them. Typically, they are rounded swelling just below the angle of mandible anterior to the sternocleidomastoid. One important pathognomic sign which is commonly associated is the notch sign. That is, a wall of this lesion will be extending between the ICA and the ECA just above the bifurcation, and this will give rise to a notch sign. So suppose if it will look something like this, a notch that will be extending between the ICA, okay, and between the ECA, and that will give to this notch sign. So this is a sign that has been reported very pathognomic. I didn't have an image about this notch sign, but it is reportedly seen with this second branchial cleft cysts. Okay, the differential diagnosis are paramedian thyroglossal duct cyst, some cystic lymph nodes, which is basically your necrotic nodal nodes. Where will you see this necrotic nodal nodes? You will see them in squamous cell carcinoma, or either you will see them with the papillary thyroid carcinoma, or it can be seen even with tuberculous adenitis. Okay, it can be also seen with some neurogenic tumors, like for an example schwannoma and neurofibroma. Okay, so these are some differentials which you should know because they commonly test. So you will usually, if it is being asked in a short case or a long case, they will give you some brief history, and that is how you can go towards the diagnosis. They will usually see your approach in handling, and you should be aware of this differential diagnosis. Now moving towards our next spotter, you can see that this is a very classical and very easy spotter image. There is a well defined bony pedunculated growth which is seen in the EAC almost at the junction of bony and the cartilaginous EAC. This is a case of EAC osteoma. A very classical case commonly tested on your spotter series. They are usually associated long term, they can be associated with the long term wax or the keratin debris which are accumulated, or it can be just incidental with no such wax found. Let's move towards our next spotter image. This is very classical. Again, it is important not only in your radiology residency, but even I would say it is very important for MBBS students who are watching this video, and also from NEET PG point of view. You can see that here there is a very fusiform enlargement of the rectus muscles. Okay, in this case there is a fusiform enlargement of the medial rectus muscles on either side. Okay, the lateral rectus is also somewhat bulky, but you can see in all the muscles there is a characteristic sparing of the tendons. Okay, so the tendons part is very relatively spared. So this is basically a case of thyroid associated orbitopathy. Okay, so if you see this case, there is sparing of the tendons, and this is in contrast to orbital pseudotumors. So in the cases of orbital pseudotumors, you will also have involvement of both the muscles as well as the tendons. Both will be involved. Everything will be enlarged. Whereas in thyroid associated orbitopathy, there is only involvement of muscles and there is no involvement of the tendon. Important thing to note is that there will be a mnemonic to remember, which is I am slow. Okay, I'm sure everyone knows this mnemonic. I am slow. I stands for, this is basically the order of involvement of the muscles in thyroid associated orbitopathy. So inferior rectus is commonly involved, followed by medial rectus, followed by superior and the lateral rectus muscle, and obliques will always come in the last. O stands for oblique. So remember, recti will always come before the oblique muscles. Now this thyroid associated orbitopathy, why these muscles are enlarged? This is mainly because of an autoimmune reaction. What happens is this thyroid stimulating receptor antibodies, they will consider some self antigens in these orbital tissues, and they will react, and that will lead to excessive amount of lymphocytes and macrophage to accumulate, okay, into these particular muscles. Okay, in the long term there will be also deposition of some amount of mucopolysaccharides which will lead to this enlargement of the muscles, but there is always sparing of the tendons over here. Moving towards our next spotter image. So this is very important image, and this is very commonly tested in FRCR examinations as well as in the long cases of radiology residency examinations. Okay, you can see that this is an axial image through your brain, and this is a angio image. You can see that there is a very prominent vessel in the left retroocular region. Here you can also see that in the region of the cavernous sinus, this is not normal. This is somewhat, it is looking very bulky. Okay, and if you compare it from the right side, over here relatively it is bulky. Okay, so this is a classical case of a carotid cavernous fistula. Okay, either it is idiopathic, either it can be traumatic. If it is traumatic, they will usually give you a history of an accident, or it can be also seen with some connective tissue disorders like Marfan disease or Ehlers-Danlos syndrome. Here you can see that there is a fistula that is formed between the internal carotid and the cavernous sinus, and because of this, what happens, the cavernous sinuses are very bulky, and even the tributaries are not able to drain, so the superior ophthalmic vein will be very much bulky and enlarged. Okay, another thing is that they will be usually giving you a history of subconjunctival hemorrhages or a pulsatile exophthalmos or proptosis associated in the affected eye region. So these are very important keywords which you should know with the CCF history, right? Now let's move towards our next spotter image. Okay, so this is again very classical spotter image. You can see that there is a mass like this. Okay, but very important is to see the pattern over here. You can see that it somewhat looks like that of the cerebral gyrations in the brain. Okay, if you see this particular image, you can see, so this is basically a T2 weighted image, and this is a T1 post contrast image. Okay, and you can see that this is somewhat looking like a cerebriform appearance, right? So this is a case of inverted papilloma. which is also called as the Schneiderian papilloma. Okay, they have this classical convoluted cerebriform pattern. These are non-cancerous sinonasal tumors which commonly affects the middle-aged men. They may rarely undergo malignant transformation, but if they go, they can convert into a squamous cell carcinoma. Important thing to note is that they may start from the lateral nasal cavity. Okay, most commonly it basically starts from your middle turbinates, and then they can extend through the maxillary ostium into the maxillary sinuses. So these lesions are very, very hyper intense on T2 weighted images, and they also show an avid post contrast enhancement. Okay, so very important thing to note is that they have this cerebriform appearance, and because of the resemblance to the cerebral cortical gyrations. Okay. Moving towards our last spotter image. So this is again very, very classical image. You can see that there is a very well defined radiolucency over here, and in this radiolucency you can see that there is an impacted tooth. Okay, so this is a classical case of a dentigerous cyst. Okay, so these dentigerous cysts are nothing, they are basically some follicular cysts which are slow growing benign and non-inflammatory odontogenic cysts which are developmental in origin. Okay, they are usually seen surrounding the crown of an unerupted tooth or an impacted tooth. Okay, and commonly it is seen in the mandible region. These are the second most common odontogenic cysts. What are the most common odontogenic cysts? They are the periapical cysts. So these cysts are so talking about these dentigerous cysts, they are usually unilocular, and they can be expansile, and they can lead to local bony remodeling also. Okay, and they hardly cause any cortical breach, but they may have either a thin regular sclerotic margin. They can expand the overlying cortex, but they do not cause any significant cortical breach, as in contrast to your ameloblastomas that are locally very, very aggressive lesions, right? So that was about this spotter image. So a quick spotter quiz for you guys. Please look at this particular image, and this is very, very commonly tested in FRCR examinations and also on your long cases of radiology vivas. So please think about this image. I'll just give you a hint that it is a very, very rare syndrome, and please comment down in the section your answers, and I will get back to you over there in the comment sections. Thank you for listening, and I hope that this was useful. This is Dr. Natisha Arora, and do like and subscribe my channel. Thank you so much.